Welcome to today's lecture on acute respiratory distress syndrome, ARDS. In this comprehensive script, we will delve into the intricacies of ARDS, covering its definition, etiology, and incidence. We will explore the underlying pathophysiology and mechanisms involved in the development of ARDS. Additionally, we will discuss the clinical presentation, diagnostic evaluation, severity scoring, ventilator management, hemodynamic support, adjunctive therapies, pulmonary morphology, complications and prognosis, pharmacological interventions, epidemiology and prevention, as well as emerging research and future directions for ARDS management. ARDS is a severe respiratory condition characterized by acute lung injury leading to hypoxemic respiratory failure. It can be caused by direct lung injury, such as pneumonia or aspiration, or indirect injury due to systemic inflammation. The global incidence of ARDS is estimated to be around 10 cases per 100,000 people. The pathophysiology involves an initial insult triggering an inflammatory response, leading to increased permeability of the alveolar capillary barrier, impaired gas exchange, and subsequent tissue damage. Patients with ARDS commonly present with dyspnea, rapid breathing, tachypnea, and cyanosis. Other signs and symptoms may include crackles on lung auscultation, decreased breath sounds, and respiratory distress. Risk factors for the development of ARDS include severe infections, trauma, inhalation of toxic substances, aspiration, shock, and sepsis. Predisposing conditions, such as chronic lung diseases, smoking, and immunocompromised states, can also increase the susceptibility to ARDS. Chest X-ray and CT scans are essential imaging modalities used in the diagnostic evaluation of ARDS. Chest X-rays typically reveal bilateral diffuse infiltrates, often described as ground glass opacities or whiteout appearance. CT scans provide a more detailed assessment of lung involvement. Laboratory tests, including arterial blood gas analysis, complete blood count, and biomarkers, such as lactate dehydrogenase and surfactant protein levels, aid in confirming the diagnosis and assessing disease severity. The severity of ARDS is determined using scoring systems, such as the Berlin criteria. This classification stratifies patients into mild, moderate, and severe categories based on a combination of oxygenation impairment and positive end expiratory pressure (PEP) requirement. The severity of ARDS influences patient outcomes, including mortality rates, length of hospital stay, and ventilator dependence. It also guides the selection of appropriate management strategies. Mechanical ventilation is a cornerstone of ARDS management. Ventilatory strategies aim to optimize oxygenation while minimizing ventilator-induced lung injury. Low tidal volume ventilation, typically around 6 ml/kg of ideal body weight, has been shown to decrease mortality in ARDS patients. PEEP, positive pressure applied at the end of expiration, helps recruit collapsed alveoli and improves oxygenation. The selection of appropriate ventilatory parameters is crucial to prevent further lung damage. Optimizing hemodynamic support is essential in ARDS management. Fluid management strategies, including conservative fluid administration and diuretic therapy, aim to prevent fluid overload, which can worsen lung injury. In severe cases, vasopressors and inotropes may be necessary to maintain adequate blood pressure and perfusion. Prone positioning, where patients are placed face down, has been shown to improve oxygenation by redistributing lung perfusion and reducing alveolar collapse. It is considered an adjunctive therapy in ARDS management. In severe ARDS cases refractory to conventional treatments, extracorporeal membrane oxygenation, ECMO, can provide temporary cardiopulmonary support, allowing the lungs to rest and heal. Histopathological examination of lung tissue in ARDS patients reveals characteristic findings of diffuse alveolar damage, DAD. DAD is the hallmark pathological feature and consists of hyaline membranes, inflammation, necrosis, and fibrin deposition within alveoli. Distinguishing ARDS-associated DAD from other causes of lung injury is crucial for accurate diagnosis and appropriate management. ARDS is associated with various complications, including ventilator-associated pneumonia and pneumothorax. Implementing infection control measures, such as strict hand hygiene and targeted antibiotic therapy, can help prevent and manage these complications. Assessing the long-term prognosis and identifying prognostic factors in ARDS survivors, such as age, comorbidities, and ventilator-free days, aids in optimizing patient care and rehabilitation. Pharmacological interventions play a role in the management of ARDS. Corticosteroids, administered in specific situations, such as uncontrolled inflammation, may improve outcomes in some patients. Other immunomodulatory agents, such as monoclonal antibodies and cytokine antagonists, are currently undergoing investigation. Additionally, emerging therapies, including mesenchymal stem cells, hold promise in the treatment of ARDS and are subjects of ongoing research. ARDS exhibits geographical variations in terms of incidence and etiology. It prevails more commonly in critically ill patients admitted to intensive care units. Implementing preventive measures, such as lung protective ventilation strategies, early recognition and treatment of risk factors, and infection control practices, can help reduce the occurrence and severity of ARDS. Understanding the epidemiological trends assists in tailoring preventative strategies. Ongoing research in ARDS focuses on identifying novel therapeutic targets and potential breakthroughs in disease management. Current areas of research include the exploration of anti-inflammatory agents, stem cell therapy, gene therapy, and precision medicine approaches. Clinical trials continue to evaluate the efficacy and safety of various interventions. These advancements hold promise for improving outcomes and transforming the management of ARDS. ARDS is a complex and challenging respiratory condition that affects critical care patients. Despite its difficulties, ongoing research and management strategies provide hope for better outcomes and care in the future.